Assalamu alaikum, everyone. I'm very happy to be part of today's presentation to improve the health of our patient with Down syndrome. Today, I'm gonna touch base on the topic of mental health in Down syndrome, focusing on anxiety disorders. I'm Dr. Bariah Dardari. I'm the chair of Child Health Department at Faqih University Hospital. I have interest in developmental pediatrics and mental health. So mental health is very common in patients in general, and we are seeing increase in prevalence across the board in non-Down syndrome, basically neurotypical patient, as well as Down syndrome patient. We know that both children and adults with Down syndrome have increased risk of psychiatric disorder, and an estimated that almost half of the children and throughout the adult lifespan, our population with Down syndrome can face major mental health problems. These are even higher prevalence in children and adults with other medical problems that is common with our patients with Down syndrome. The psychiatric condition that we can see can range from major depression, mood disorder, bipolar disorder, anxiety disorder, OCD, ADHD, attention deficit hyperactivity disorder, as well as autism spectrum features, and very rarely psychosis. Other studies focusing on kids with Down syndrome estimated that this prevalence is between 18 to 38%. It depends on the population studied and depending on the language and communication impairment in the child with Down syndrome, as well as the intellectual disability and the age. One of the common mental health disorders in Downs is general anxiety disorder, as well as repetitive obsessive compulsive behavior, as mentioned earlier, as well as neuropsychological problems characterized by progressive loss of cognitive skills. And as we mentioned earlier, depression, ASD spectrum, and one of the most common also behavior problem is the oppositional, impulsive, and inattentive behaviors. So today I'm focusing on generalized anxiety disorder, as I said, and it's actually one of the most prominent issue among children and adults with Down syndrome. So it's very important to know how to diagnose it and also how to differentiate it from other conditions, because some of the signs and symptoms can overlap with other behaviors that we see with our kids. So the anxiety can be of two types. There could be a baseline where the child is always anxious, or it could be situational anxiety, where there are certain clear-cut stressors that are triggering this anxiety in the child. So usually situational anxiety is apparent when there's a transition or if there's anticipation of a new situation. Example for this transition could be transitioning from home to school. So basically the first semester in school, or change in school, or even transitioning of activities. So between mealtime to bedtime, or from home to school, or any unfamiliar situation where there's uncertain expectations. So usually in generalized anxiety disorder in kids can present with different signs and symptoms, including impaired concentration, irritability, difficulty sleeping, restlessness, fatigue, excessive worry, and increase in muscle tone or muscle soreness. However, majority of our kids, especially the nonverbal kids with Down syndrome, can have very difficult difficulty in communicating all these symptoms. Also, some of these symptoms can be already present in that child with, let's say, obstructive sleep apnea, can have difficulty sleeping, restlessness could be related to hyperactivity rather than anxiety. So it's very important to get a very detailed history, as we're gonna discuss later. So also there's a lot of overlap between anxiety and oppositional defiant disorder or behavior, as well as the obsessive compulsive symptoms. And very often the OCD behavior can coexist with anxiety, and or if we prevent the child from attending to his obsessions, that can create anxiety. So sometimes it's very hard to understand which one comes first, or to delineate between the anxiety and obsessive compulsive behavior. So also the increased restlessness and worry in the anxious kid may make him behave in a rigid manner and being in a state of being stuck. And then because he's stuck and he's anxious, he might want to do familiar routines. Hence, the OCD behavior becomes more apparent. Usually, they are very unhappy or stressed out or fearful when it's related to the anxiety, versus the disruptive behavior that we see with oppositional defined behavior. The child is not stressed out, he's not unhappy, he's actually acting silly, happy, or excited. So this is one way to differentiate between oppositional behavior and anxiety and OCD behavior. It is a challenging situation for the parents, because when the child becomes stuck and engages in negative behavior, then the parents or the caregiver give this negative attention, which basically reinforces that behavior, and then the parents and the family and the child will go into a vicious cycle of repetitive of the behavior and negative reinforcement. So also it's very important to differentiate the anxiety from the ADHD symptoms. So usually the restlessness and fidgetiness that we see with the patient with generalized anxiety have a clear onset, and it's more intermittent. So sometimes it's there, sometimes it's not. Whereas the restlessness in our Down syndrome kiddos with ADHD is usually constant. They're always on the go, they're always hyperactive and have short attention span. So that's one way to delineate. Also, from the detailed history, as we discussed, it's really helped us find out the situation or the triggers that triggers this behavior. So let's say if it's transitioning or change in the environment that's causing the restlessness, then it's probably anxiety. Versus if it's related to academic work or certain activities that the child is having difficulty focusing on, then it's probably related to attention deficit and hyperactivity. So when we want to diagnose, as we discussed in the previous slides, it's very important then to have a comprehensive approach. We cannot just label the child of anxiety disorder or ADHD or any other behavior without looking at the whole picture. We don't want to brush it off as expected behavior or normal behavior. It's very crucial also to rule out the underlying medical or neurological conditions. We also have to think about the side effect of certain medication. If the child is on any medication, cardiac, neurological medication, or hormonal medication for the thyroid, is very important to also understand if there's any interaction between these medications, or that these medications can be causing mood instability. So always we have to consider that maybe there's a possible mood disorder, especially when there's a sudden change in the behavior, when the child becomes suddenly either persistently oppositional or impulsive, disruptive, irritable, or aggressive. So there are medical causes that can coexist or can cause the behaviors and the mood disorder. So it's very important to look into each condition. Definitely the thyroid function test needs to be done, and it's anywhere should be routinely done every 6 months for all of our kids with the Down syndrome. Also very, very high on the list is any sleep-related difficulties, such as obstructive sleep apnea, which is also very common in our kids. Majority of our kids require tonsillectomy, adenectomy by age of 5 because of the obstructive sleep apnea. And that definitely will affect the sleep quality and may cause hyperactivity, irritability during the day that may confuse the picture. Also, it's very important to review the diet of the child, because usually high sugar, high food additives, and food coloring diet can cause hyperactivity and poor focus. As well as looking into any gastrointestinal issues such as constipation, reflux, that definitely can cause irritability of the child, which could be interpreted as anxiety or behavior problem, as well as other conditions such as vision problem, hearing problems, audiology problems. So also we need to understand that our children with the DS are very sensitive to psychosocial and environmental stressors. So a simple event or a small event might not trigger a problem with a neurotypical kid, but might trigger a problem with our kids with DS. So it could be an illness of a family member or a loss of a close one, not necessarily permanent loss, but let's say travel for a long period of time. This can cause a complicated grief reaction during this time, and it can cause regression in that child and causing him difficulty of thinking, reasoning, remembering, processing information. So this psychosocial environmental triggers can lead to this state of generalized anxiety, and as well as other problems, as we said, such as OCD. It might even trigger physical problems such as weight loss, poor self-care, and inability to be motivated to go to school. So very important to always get that history as well and remove any environmental triggers if possible. So there's definitely improvement in the way we diagnose the anxiety disorder in kids with Down syndromes. In the past, it used to be very hard to objectively diagnose it because most of the standardized questionnaire and tests were not built for our population. So the diagnosis was more clinical based on history and observation. However, now there is a wider range of available screening diagnostic tools to assess in general the mental condition of our kids with DS, as well as, of course, their developmental age and other domains such as the nonverbal problem-solving abilities, the language communication, and adaptive and functional behavior. One of these scales is what's called SCARE-DS. It's the screen for child anxiety-related emotional disorder. That scale was already available for non-DS kids, for neurotypical kids, and it was also used for autism kids. However, recently it was modified by removing a few items from the questionnaire and simplifying the language of these questionnaire to make it more easier for a child with Down syndrome or an adult or a parent of a Down syndrome to fill that questionnaire and to scan objectively for the generalized anxiety disorder. And it did show that it's a useful tool and it's a valid tool to assess anxiety in children and youth with DS and see who will be eligible for clinical treatment. So that brings us to the treatment part. The treatment obviously is different folds. Definitely behavior therapy is the most important. So starting with assessment of the antecedent, like what we said, the triggers, the environmental triggers, the events, and assessment of the behaviors as a reaction to those events and the consequences, like the ABC model that already perhaps the behavior therapists are using with our kids. And then develop a behavior modification and management plan, as we said, to remove the negative reinforcers and use more of a positive reinforcer during the anxiety episode. Obviously, some of our kids don't respond fully to the behavior therapy, and then we have to consider medication, including antidepressant, anti-anxiety medication, but it should be reserved for the persistent and serious symptoms that are not improving with the behavior therapy. So there are several treatments that we use, and we try to be as specific as possible, and that's why it's very important to know what's the true diagnosis of the child in an objective way, so we don't mistreat, undertreat, or overtreat. So for anxiety, we can start as a first line with a medication called buspirone. And the second line will be the SSRIs, the serotonin increasing medication, the serotonin reuptake inhibitors, which also we use for kids with mood disorders, our kids with DS with mood disorders. Kids with obsessive compulsive behavior also will respond to the SSRIs. However, kids with stereotypical behavior, so this is very important then to differentiate, will respond to the buspirone. Kids with ADHD, and that could be a coexistence. So we might have a child with ADHD and anxiety, or ADHD and OCD. Then as a first line, we utilize a medication called guanfacine. Unfortunately, it's not readily available in Dubai. Then second line of medication will be Strattera. And very rarely we use Concerta or Ritalin, because most of our kids, they don't do well with these medications. They become actually more irritable. For a patient with irritability or psychotic symptoms, then we use the antipsychotics such as Risperdal or Compify. The name is aripiprazole. So, and then for bipolar disorder, which is we see with older, like teens and adults with DS, then we use other medications. So that's why it's very important to have a mental health provider to delineate where the patient is and to go stepwise approach with the medication. Now, we also can use anticonvulsant medication like anti-seizure medication as a mood stabilizer. But that should be all medication, including this medication, should be given under careful supervision, because these medications can have a side effect, as we said, increasing irritability, drowsiness, but also can increase the weight. And that already is a problem with our kids with DS. And a few of these medications, such as Risperdal, increases appetite. So that compounds and make the problem weight gain even worse with these kids. Now, that's why we sometimes use either as a first line or as a medical treatment with the medication, what we call the alternative treatment, using natural supplements such as magnesium, high dose magnesium, 400 milligram per kilo was proved to decrease anxiety and hyperactivity in kids with anxiety disorder in DS. Another supplement is called 5-HTP, 5-hydroxytryptophan. Also, it's a natural supplement to increase the serotonin in the body and can have a positive effect on some of our kids. Other supplements such as L-theanine and GABA, which are amino acids, also can have calming effect on the brain and reduce the irritability and the emotionality of the kids during the anxiety attack. Of course, other methods such as exercise, breathing exercises, and yoga can have also huge impact, and it should be part of like a multidisciplinary treatment approach. Also, our kids with DS and mental disorder, anxiety disorder should have access to quality mental health that caters for their needs. So we need to find a good practitioner who understand the complexity of the Down syndrome patient and understand all potential treatments and options and able to appropriately choose which one at which stage, and to be proactive, not wait until the behavior is becoming a second habit or become irreversible. Focus on the strength of the patient and use that as part of his behavior therapy. Be flexible, that use different methods depending on the situation, let's say in the school or at home. Be multidisciplinary, work with other therapists, other teachers, and family members who care for the kid with DS. And also, once the child is older, teenager or pre-adult, then we have to empower them and include them in their treatment plan. Some of the mental health strategy that we can encourage our kids with Down syndrome to use is simple strategies such as self-talk. So our kids, everybody self-talk, even non-Down neurotypical people. The difference between us is that we self-talk in silently, but our kids with Down syndrome may self-talk in a loud out loud. But it's important not to suppress that self-talk because it helps the kids with DS to problem solve. It helps them to vent feelings and to process their thoughts, as well as process the events and feelings, and to express their imagination and fantasies. Also have a benefit for the parent as the child is self-talking to understand what's the child with DS is going through and what is he's experiencing. So it's very normal for kids with DS to have high imagination, have imaginary friends, even at an adult or adolescent stage, not necessarily as children. And that's a good thing, and it's a coping strategy, and we shouldn't suppress it as much as possible. Another important strategy is maintaining the routine. So we know that our majority of our kids with DS thrive on routine and make it less likely for them to develop anxiety symptoms. So it helps them make life more predictable, helping them to relax at the end of the day. Also, to support them to when we have a regular routine, then the people around them also can know what to expect. And if the routine, though, becomes very rigid and it's interfering with the child's ability to function in school or at work or at home, then it becomes a problematic, and then it needs to be addressed. And then we have to use other method to prepare the child that the routine would be changed, and by giving visual reminder or preparing the child before the change of the routine. So other tips to support our kids with DS, with anxiety disorder, is to, as we said, to becoming actively involved in their own decisions, especially as they become a bit older and become preteen. And as we said, respect their healthy routines as part of their therapy program, actually. And find a good general practitioner who can attend for all their needs, physical and mental, because as we saw before, it's very interlinked. we have to always think of mental and physical, and also to be mindful of that the transitional period will be difficult for them when they transition from school to college, from college to work. Any transition has to be anticipated, and children needs to be prepared for that. Very important other tips is the friendship, that to help them make friendship and maintain this friendship, and encourage them, especially as a young DS patient, to have a peer support where they can have, opportunity to develop their friendship, such as sport events, sports activity, and basically, if possible, create a formal support network for the patient with DS and anxiety, especially as an adult or teenager. And not to assume that, as we said, the behavior is part of Down syndrome. If the child is acting anxious, he's having panic attacks, if he's showing distress, then we have to address it and not brush it off as just part of the syndrome itself. So we also have to teach them tips to talk about the feeling. Sometimes it's difficult with our kids with DS who have limited verbal communication. So we can use visual aids. We can help them, by showing how people name and describe their feeling. We can also read books about describing their feeling, or movies such as Inside Out, which is an amazing movie. So any visual or alternative aid, such as books, movies, brainstorming, visual aids, all of that will definitely help them talk about the feeling, which will make it easier when they're in the middle of the anxiety attack, to express their feelings and not engage in the negative behavior. So that's it for today. I think the topic is very big, and it requires attention, but I think that's my time for now. And if you have any questions, you're more welcome to communicate with me via the email. I'm very happy that we shed some light about the mental health issues with our kids with DS. And thank you very much for the amazing work you do. Take care.